today's lecture. We have quite decent amount of things to cover today. So today's topic is about ear and temporal bone. So here are the categories I'm going to cover during this morning. So the first one is LCH, Langerhans cell histiocytosis. So the Sternberg still put this diagnosis in this chapter, but I think in the lung and in the skin we see more of this diagnosis. So but in the expert path, they have a really good definition of this. Actually, this Langerhans cell histiocytosis is the myeloid dendritic cells expressing the Langerhans cell marker. So it could be an isolated lesion or maybe part of systemic disease. So the microscopic feature a lot of content here, but I just highlight the thing we need to know. First is rich inflammatory cells, especially the eosinophil. Let me have the pointer. Yes, especially eosinophil. And then high power, we need to see the cytology feature of the Langerhans cell, especially that coffee bean, then nuclear groove and folds. And also the immunostaining is really helpful. That is S100, CD1A, and Langerhans CD207 positive. And then the genetic marker is the BRAF V600E mutation in up to 85% of the patient. And then electron microscope is the Burback granule. So if we have everything just fits, but just S100 and CD1A positive, but Langerhans negative, we call that indeterminate dendritic cell histiocytosis. So just the marker is different, but what you see in the microscope are the same. So here's the MR of this LCH in the ear and temporal bone. So we can see kind of infiltrated mass and then a little bit bright signal. And then in the microscope, we just can see this sheet of cell intermingle with tons of inflammatory cell. And then here just highlight this tons of eosinophil. So if you see sheets of cells mixed with inflammatory cell and tons of eosinophil, the major differential, even in really low power, you need to think about LCH and then mastocytosis. And then and another category I would talk about is the ALHL, aka Epithelioid Hemangioma. All of these three, most of the time you will find this eosinophil, and then really helpful for you to put the differential even in low power. And then we also focus on this cytology feature, this nuclear groove, some coffee bean-like cells, and then also tons of eosinophil, and then nuclear groove. And then you can do your immunostaining to make sure of your diagnosis. So then the next category is heterotopia. Here, especially they highlight in these spectral anatomic sites, we may find some neural tissue. So just like this image looks like a normal brain, we have some neuron and then some gliocytes, and then this neurofilament neuropil, the eosinophilic neuropil. And then they also you can also find these reactive changes, like compare this relatively normal, and then this one looks like reactive. We have more glial cells. So when you see this, the diagnosis, you can put heterotopia, and then they also have a name is acquired encephaloceles. And then another category is about skin and soft tissue. So the first one about the ocular area is the relapsing polychondritis. And for this one, this is a degeneration of the cartilage structure through the whole body, but because the ear had this cartilage area, so patient usually will have this finding, and then really easy to observed by the clinician, and usually bilateral. And then we can see this red erythematous, swollen, and the patient will tell you really tender. We can have some laboratory finding to support, but not specific at all. We can see elevated ESR, and then mild leukocytosis, anemia, even ANCA antibody titer may be increased. So for the microscopic feature, I put a normal cartilage here as a comparison. So in the normal cartilage, we can see these chondrocytes. They have really distinct of this vacuole around it. And then the color is really bluish. So this is the normal cartilage and chondrocytes. And then in this relapsing polychondritis, we can see really pink compared to this bluish because they lose this mucopolysaccharide matrix. So they become really pink. And then you can see the chondrocyte is not really happy. You can see compare this, they have really distinct this vacuole. But here it seems they lose it. So they lose the matrix and then lose this vacuole. And then when we see the periphery of the normal cartilage, usually we do not see tons of inflammatory cells, especially neutrophils. We just can see this fibroconnected tissue. But in the relapsing polychondritis, we can see tons of inflammatory cells, especially when you see neutrophil here. That is the clue for this diagnosis. So here's another image. We can see the chondrocytes. This cartilage is not blue at all. And then some lose their nucleus, so that means they are dying. And then in the periphery, they have this fibroconnected tissue. But more important, we can see some neutrophil and more inflammatory cells around. So this digital slide, I will go through it later. One differential diagnosis, when the patient come here, they tell you the tenderness in the ear. One major differential is this ocular pseudocyst. So I will talk about this in the virtual slide, but what we can see is in the relapsing polychondritis, the pathology changes is this is the skin. In the outside of the pathology change, we can see this chondrocytes, not happy chondrocyte, and then neutrophil, just in the outside of the cartilage. But in this pseudocyst, you can see the pathology changes is inside of the cartilage. So even in low power, we can tell the difference. And then basically just this cartilage had some degeneration changes, so this is forming this cyst, but without epithelial lining. So we call this pseudocyst. And then another high power, from the outside, we do not see the pathology changes, but just inside. Yeah, so let's see. The first one is reactive polychondritis. So this is the skin, this is the skin. Even in low power, we do not see any pathology changes here. But what we can see is in the periphery. So this chondrocyte is really eosinophilic, not blue at all. And then some may lose their nucleus, they are dying. And then in the periphery, not only this fibroconnected tissue, we can see a lot of inflammatory cells here. And then when we look for more, we may see some neutrophil around. So when we see this feature, there's a relapsing polychondritis. And then here's as a contrast. Another one, this is the auricular pseudocyst. So even in low power, we can see there is something on inside the cartilage, nothing outside. So we can take a look at it. In the outside, we still can see this bluish chondrite, but inside we can see this pseudocyst. inside this area. So this is a really good comparison. So nothing inside, there is something inside. So this is the pseudocyst, this is relapsing polychondritis. Let's continue. Another differential in the ear auricle is this CNH, Chondrodermatitis nodulari helix. So the image, they just can show you a little bit maybe erosion or ulcer in the auricle, but still, because this is some inflammatory changes, the patient still tell you they feel some tenderness in the auricle, and then also this redness, something really similar to the previous two diagnoses. But in the microscope, we know this is erosion or even ulceration from the epidermal surface go to inside, and then we can see this epidermis is dying, and then we can see this almost look like vasculopathy, but this is reactive changes to this ulceration, so this blood vessel. And then we can see this fibrinoid necrosis material here, and then all of these are reactive changes to this ulceration area. Here is the same. We can see this ulceration, then we can see this fibrinoid material here. So basically the mechanism of this disease is we have some injury, some trauma of our cartilage, and then our skin want to push this traumatized cartilage out. So they produce this area hole and then trying to push something out. So all of these are the reactive changes. So this is a CNH whole slide image. We can see the cartilage here, and then we can also see this erosion or ulceration area. Let's focus on this piece first. So you can see tons of granulation tissue dilated web cell here, a little bit this fibrinoid necrosis material, and then the cartilage inside. So the epidermis just would like to push this dying or traumatized cartilage out. So all of these pathology changes. So sometimes if you do not have this cartilage, but you know the clinical information that is from the auricle, and then you can see the ulceration, all of these reactive changes, you can still make the diagnosis of CNH. Let's see one more. So we can see this ulceration area, fibrinoid material, and then some dilated web cell, and then not healthy cartilage. So combine all of this feature, this is the diagnosis of CNH. Okay, next one is gout. So also really common to see the gout. This is the monosodium urate crystal deposition in the auricle. And then another common area is the finger. So the microscopic feature is really easy. We can see this needle-shaped foreign material, and then surrounding, because the histiocytes will hugging whatever they think is not a normal material in the human being. So they have this multinucleus giant cells, and then they have histiocytes forming this a little bit palisading granuloma pattern to just hugging, and then with this needle-shaped material. And then this is the polarization. So one important thing is that if the clinician think of gout, when they get this kind of stuff, they will also put some in the alcohol fix so we can polarize. If we use formalin fix, we could not see this polarization. And then one differential diagnosis is a rheumatoid nodule. So we can see this necrotizing, really eosinophilic granulomatous inflammation. They also have this histiocyte to palisade around, even in low power. But this material is totally different than the needle-shaped material from the gout, needle-shaped crystal from the gout. So let's to slide. So this is the gout. Even in this power, we can see really different from the rheumatoid nodule. Even just the pattern look like the same, something hugging around, but the material inside is this crystal is kind of feathery needle shape, and then this is the histiocytes surrounded. So this is really good for gout. The other one, this is rheumatoid nodule. We know this ankle skin, not from the ear. And then we can see this eosinophilic necrosis material. And then we have histiocyte around. So this is good for rheumatoid nodule. But one important thing is that because this is from ankle skin, so one scary differential should be epithelioid sarcoma. So you need to take a look at this histiocyte. Do you see any atypical epithelioid cell, really hypochromatic and mitosis and another thing? So every time when you see this red granuloma, polycytic granuloma pattern, you need to take a look at it in hyper to make sure there is nothing wrong here. Okay, the next one is Wagner disease, but right now we do not use that name. We used a granulomatosis with polyangiitis. So this is an ANCA-associated necrotizing vasculitis. So in a human being, where we have this small to middle-sized vessel, we can see these pathology changes. I think the classic one is from the nasal, and then from the throat, and then also can find it in the lung and also in the kidney. And then this CNCA is elevated PR3, that's proteinase 3 ANCA. So the classic triad of this diagnosis is vasculitis. We can see some vessel damage by inflammatory cell, and then fibrinoid necrosis material, and then we may see some granuloma, not well-formed granuloma, and then tissue necrosis. So the next one is Paget's disease of the bone, aka osteitis deformans. So the clinical symptom of this disease is hearing loss, tinnitus, and vertigo. So the microscopic feature, they have different stage, but the mechanism of this disease is kind of osteoclast and osteoblast. They just break the balance of these two types of cells. So usually in initial stage, the osteoblast is trying to destroy the bone, and then the osteoblast would like to have this balance. So when this kind of osteoclast want to destroy the bone, and then this osteoblast would like to remodel the bone. So what you can see of this is the Paget's disease. So you can see this. This is reactive bone because we do not see really nice lamellae. So this is the bone. This is the new forming bone after the osteoclast destroy the bone, and then osteoblast would like to have a new bone. So the feature is that you can see this reactive bone, and then sometimes you will see more osteoclast, and then with this osteoblast, especially in the initial stage. And then here's the same feature. We can see this is crack. That means this is not a mature bone. This is a new bone, but they just do not have a really good structure. And then this osteoclast destroy the bone, and then osteoblasts want to fix the bone. And then in the late stage, they will induce this fibrosis around. This just show the osteoclast and osteoblast, and then of this reactive bone. This is here show the same feature. Another one also in the ear, you can see this papule and subcutaneous nodule. They can have this, they can have a single one, or maybe they have a lot, forming this group. And then we have two names. In derm, they usually use the ALHL, Angiolymphoid Hyperplasia with Eosinophilia. So for this name, you should find tons of eosinophil. And then I think in the soft tissue world, they would like to use Epithelioid Hemangioma. So the microscopic feature is that this papule or nodule, we can see this skin, something just like a papule or nodule just popping out. And then even in this low power, we can see tons of this dilated big vessel inside, kind of forming this vaguely lobular feature. And then we can see tons of bluish, this is the inflammatory cells. And then when we have high power, we can see this endothelial cell is really plumped. And then what's more important, that is the eosinophil. We have tons of eosinophil here. And then another one, we can see some dilated vessel. And then especially for this vaguely lobular pattern, especially tons of vessel also form surround this big vessel, just like this. But in the low power, we just could not appreciate a lot of vessel. And then this is the high power. We can see this big one with plump endothelial cells. And then this small vessel around when you go to high power, but they usually just the lumen is not really easy to appreciate. But if you have this differential, you will try to find this small vessel, try to fit this big one. So this is one of the characteristic feature. This is another one, small vessel, big vessel, and then tons of eosinophil. Here's the high power, just show you how plump of these endothelial cells. So the immunomarker, commonly because this is vessel, so we can use CD31 stain and also ERK. And then one genetic finding is this FOS or FOSB. So if anything you're not sure, you can send for this rearrangement for the fish. So one differential diagnosis is Camera disease. So this is more, what I understand is that if you find this reactive lymphoid follicle, and then with the eosinophil, and then like this ALHL or epithelioid hemangioma with the reactive lymphoid follicle, you consider this Camera disease. And also you can find it in Asian. So this is the epithelioid hemangioma. So even in low power, we can see dilated vessel. Here should be some inflammatory cells. And then when we zoom in, we can see eosinophil. This one is not a lot, but still decent amount to help you think of this diagnosis. So go back to low power, this big vessel, and then surround this big vessel, we can see this tiny vessel. And then the endothelial cell kind of plumped. So combine all of these features, good for this diagnosis. This is another one. So they sometimes can forming this regularly lobular structure. And then this big vessel, small vessel around, try to fit this big one, and then try to find our eosinophil and plump endothelial cell. So all of these are good for the epithelioid hemangioma. Some people may also think about, make confused of the pyogenic granuloma, aka lobular capillary hemangioma. They're also forming this regularly lobular structure, but they usually have more open lumen of this small vessel. Then another feature, they usually have tons of inflammatory cells, but not a lot of eosinophil. So anything if you, and then they usually their surface, they will get erosion or ulceration for the pyogenic granuloma. And then if anything concerned, you can send for FISH, for FOS or FOS-B, can help you finalize the diagnosis. Okay, the next one is myxoma, cutaneous myxoma, aka superficial angiomyxoma. So this is one of the kind of complex. So if you can see multiple in other location, including the heart, and then some endocrine tumor and schwannoma, you may think of this diagnosis. So the common location for the cutaneous myxoma in the Carney complex, that's the nipple, eyelid, and the ear. So under the microscope, we can see this multi-nodular growth pattern. Then anything we call it myxoma, you should bear in your mind that you could not see anything hypercellular. It should be kind of hypocellular. I mean, other than the blood vessel endothelial cell. I mean, the tumor cell should be hypocellular. Then they can have some myxoid stroma. So when you see myxoid stroma, you really easy to find mast cell. So these two things always come together. And then from the name, we already know that superficial angiomyxoma. So it should have some vessel. And then I highlight this neutrophil here because if you can find the neutrophil, that will be really helpful. 50% of the cases you can find this neutrophil inside, because in the soft tissue world, neutrophil is a really good friend. Some neutrophil can help you make some more specific diagnosis. I can think of one is this cutaneous myxoma. Another one is pseudomyogenic hemangioendothelioma. This for the pseudomyogenic hemangioendothelioma, sometimes you may also find neutrophil to make you remind of that diagnosis. So another feature is it will entrap some annexal structure. So in low power, we can see this multi-nodular pattern separated by this fiber connected tissue. And then we can see this maybe entrap a hair follicle or somewhat annexal structure. And then even in this power, we know this is hypocellular, a little bit mucin or myxoid stroma. Then we can see this bluish stroma, we can find some tiny vessel. And then the lesional cell is this spindle cell around. Then you can start to look for this neutrophil, really helpful. So this is hypocellular with neutrophil and this spindle cell proliferation, really good for the cutaneous myxoma. So this is one example of cutaneous myxoma. So low power, really hypocellular, maybe a little bit lobulated growth, not really obvious for this one. But at least from low power, you can see some thin wall vessel, and then really hypocellular, a little bit myxoid background. And then go to high power, yes, it's really hypocellular, and then this spindle cell proliferation. And then we need to find some neutrophil. Here's some neutrophil. And then when we look more, we can see more band-like neutrophil. So when you see this, combine all of these feature neutrophil, again, you think of cutaneous myxoma. Another one, multinodular growth separated by this fibrous septate, really hypocellular, even from this low power, some vessel. And then high power, we can see this spindle cell proliferation with this myxoid background. And then we start to look for neutrophil. This is one neutrophil. Maybe this is another one. Maybe neutrophil. So when you see all of these features, that is cutaneous myxoma. Okay, the next one is a paraganglioma, but because in this special anatomic location, we have the name is Jugulotympanic Paraganglioma. So 90% of the tumor in this special area, jugular foramen area, is paraganglioma. So if the clinician find a mass or tumor around this area, 90% you will make this diagnosis. Why it is important? Because if you're suspicious for this diagnosis, do not biopsy, because really vascular and real bleeding and really difficult to stop the bleeding. So the microscopic feature, just like regular paraganglioma, and then in the adrenal gland, we call that pheochromocytoma. They are the same. So this is a nodule, and then we can see this wiggly nest forming cells, and then between this cell we can see this vascular, really a lot of vessel in this stroma. So and then high power we can see forming this cell, forming this nest. All the cells look the same. They have, if high power, we can see this salt and pepper chromatin feature for the neuroendocrine cell. And then between this nest, we can see this dilated capillary. And then the same feature, the buzzword is cell Bolen architecture for this paraganglioma. So sometimes we can see this rich vasculature, and then they also can have this fibrotic stroma. So here's the same, more fibrotic stroma separated by this cell Bolen nest. Of course, we can use our neuroendocrine marker, chromogranin, to highlight the tumor cells. And then we can use S100 to highlight these testicular cells surround this cell Bolen. And then don't forget our GATA3. GATA3 is really helpful for this diagnosis. Okay, next one is Endolymphatic Sac Tumor. I think this is really specific for this anatomic location. So this is a papillary endothelial neoplasm arising within this endolymphatic sac or duct. And then I think maybe in the exam, it may be a point for the von Hippel-Lindau syndrome reach out. And then, but this is a really slow growing tumor. So the symptom can be present for years. And of course, VHL, we can find some kidney, kidney cell carcinoma, pancreas, some neuroendocrine tumor. And then for the cerebellum, we can have so the microscopic feature, sometimes because we have the name sac in the diagnosis, so you can see this just like a cyst. But inside cyst, we grow this broad-shaped papillary structure. Sometimes they may remodel, invasion the bone. And then when we go to high power, we can see the cell, we have this eosinophilic granular cytoplasm, but their cell border is not that distinct. So you can see this is a stack of a cyst inside a bone. So I don't know whether they infiltrate into a bone or they just grow inside. But inside this cyst, we can see this broad-shaped papillary structure. Here's the bone. So you can see this tumor have this broad-shaped papillary structure just growth inside a cyst. Sometimes they can mimic kind of like thyroid gland structure, especially they can secrete this kind of just like colloid material and also this vacuole scallop like here, just like a thyroid gland. And then, but sometimes this cell may also can form this looks like nuclear groove, but the cell border is indistinct. That means you just could not tell how you could not tell one cell end and then all the cytoplasm just mixed together, and then we're in eosinophilic and granular. So this indistinct cell border is a helpful feature for the cytology. And then epithelial marker usually positive. And then one really special staining that is the CA9 and PAX-A. So similar to the clear cell renal cell carcinoma. But other marker like RCC and CD10 are negative. If you're just thinking about thyroid, of course, PAX-A positive for the thyroid, but you can use TTF1 to help you make the differential. Another one is Ceruminous Adenocarcinoma. So this is a malignancy derived from the ceruminous gland of the external auditory canal. So the symptoms are the same, everything in the ear, they can cause this tinnitus, hearing loss, and pain. So for the microscopic feature, this is not a really specific diagnosis because they can be an adenocystic carcinoma. They could be mucoepidermoid carcinoma. If the malignancy do not fit into these two features, we just put this diagnosis as NOS, just like diffuse large B-cell lymphoma. If we could not make a specific diagnosis, we just put into NOS category. So basically, if you find tumor necrosis, especially this comedonal necrosis, this is one of the diagnostic feature. And then perennial invasion, of course, can help you define malignancy. And then one special thing in this anatomic area, there is this cerumen pigment. This is a lipofuscin pigment. If it is a ceruminous adenoma, usually because they are well differentiated, so you will find this lipofuscin pigment. But in this malignancy, they usually absent. This is really helpful feature. And then another one, of course, infiltrated growth and pleomorphism. So for the malignancy, the common rule always helpful: necrosis, perineural invasion, infiltrated, and pleomorphism. So here's the normal ceruminous gland, and then this is the tumor. So they did not get involved the epidermis, so they can have this kind of gland zone, and then they have a little bit infiltrate border. So even in this power, we can see this thing maybe forming some glandular structure. And then for this one, we have the bone. So these cells, really basaloid looking cells, kind of destroy the bone. And then this is the feature of the adenocystic carcinoma. You can have this globule and then this membrane, basement membrane material secret inside. And then we also have two cell layer. And then here's the normal ceruminous gland. And then this is the tumor. And then here's the comedonal necrosis, and then the tumor just surrounding, and then really pleomorphic hyperchromatic cells. So this is characteristic feature of the malignancy. This is the feature of mucodermoid carcinoma. We have this epithelioid cell, squamous cell, and then intermediate cells, and then also this Goldberg cell. So one major differential is the benign category. This is the Ceruminous Adenoma. So this one is well circumscribed, and then this is a biphasic tumor. So that means that you can see, even in this power, you can see these two cell layer, the luminal cell and the myoepithelial cells. And then they also highlight this lipofuscin-like pigment, that is the cerumen. So this one really nice two cell layer. And then the luminal cell can have some secretory material like the decapitation-like apocrine differentiation. So here we can see this eosinophilic apocrine differentiation cell, and then luminal cell, and with this myoepithelial cell two cell layer. And then this is the one I want to highlight for this category. This is the cerumen granule. That's just like lipofuscin-like. So in the benign category, if you find this, you will thinking this is definitely benign. But in the adenocarcinoma, you won't find this lipofuscin-like pigment like here. And then the next category is squamous cell carcinoma. And then in the Sternberg, they especially put this acantholytic squamous cell carcinoma. Maybe in the ENT area, they can find this pattern, but it has really rare pattern, but really good to pay attention to it, because when the cell, this is classic squamous cell carcinoma area, but when the cell falling apart acantholytic, that means the cell just falling apart. So they can forming this, they call it pseudo-granular appearance. So sometimes you will think whether this is adenocarcinoma, but in the skin, adenocarcinoma is really rare. Yeah, and then another one for the differential for this is the AFX, atypical fibroxanthoma. So what you're basically just seeing kind of ulceration, and then really pleomorphic cell. So and then some foamy site. Why we call this a xanthoma? Because we have this foamy site cell, but the cell is really pleomorphic, really ugly, mitosis just everywhere. And then the major differential for this one is the diagnosis of exclusion, because not any specific marker can make you help you make the diagnosis. So what you need to rule out, of course, is the melanoma, squamous cell carcinoma, leiomyosarcoma, and angiosarcoma. So when you do the staining like SOX10, S100, to rule out melanoma, then CK56, P60, P40 rule out squamous cell, Desmin rule out leiomyosarcoma, CD31 and ERK to rule out angiosarcoma, and then you make the diagnosis of AFX. But if just in the superficial dermis and the epidermis, we call this atypical fibroxanthoma. If we're going down, we'll call it a different name. I have the last digital slide to show, and then we are done. So this is a skin. We can see this whole inside, some cell falling apart. And then I think here we have some conventional area for the squamous cells. Like this area, this conventional squamous cell material. And then when the cell falling apart, it's just forming this hole to just trick you like a granular pattern. But when you see a little bit cell inside, actually this is the acantholytic squamous cell carcinoma. It is reported this pattern is kind of more aggressive than the conventional one. So when you see this pattern, I think it's also important to put into your report to describe this pattern. And then this is the AFX. So still really pleomorphic cell, really ugly, mitosis, really pleomorphic, and then this lymphomas stroma. So when you see this pattern, just do the immunostaining to rule out other diagnosis, and then you can make the atypical fibroxanthoma diagnosis. I think